G'day, and welcome to the emergency department. My name is Dr. Coyce, and I'll be looking after you this afternoon. This phrase, when said with this accent in an American emergency department, is an incredibly powerful pain reliever. Almost always, the patient will stop writhing around on the bed, look up at you and say, "Are you from Australia?" Australians live 7 years longer than Americans. Geez, what a provocative way for an Aussie to start a talk in a room full of Americans. Let's see how this goes. But it is curious to me. We Aussies love red meat and engage in dangerous activities like Australian rules football. We love and share so many things about American culture, including a love of fast and processed foods. And if you get bitten by a brown snake out in the bush, you better hope you're not stuck out in the bush. So what makes the US different? Life expectancy in Australia from birth is 84 years versus 77 years in the US. The leading cause of death in both countries is cardiovascular disease. 32% of Aussies are obese, while 42% of Americans are obese. 8% of people smoke cigarettes down under, while 11% of Americans smoke cigarettes. Almost double the amount of Americans carry a diagnosis of some form of diabetes compared with us Aussies. Perhaps we just don't spend enough on healthcare in the US. We spend a staggering 17% of GDP on healthcare in the US, compared with 10% in Australia. Over half of those dollars are spent in the senior years when disease risk is already accumulated. Okay, so there are some differences, preventable death rates. How about we address the elephant in the room? Our healthcare system. It's almost a daily occurrence that patients, colleagues, even the media suggest that our healthcare system is a mess. Before I was treating pain in emergency departments with my voice alone, I worked in Australia providing obstetric care to vulnerable Australians in rural settings. As I was finishing my medical school exams, my wife came to me and told me that we were expecting our first child. She is an American, and she had access to our Medicare system, publicly funded, because she was a permanent resident. She received her care at the local publicly funded hospital free of charge. We had numerous visits with obstetricians, midwives, and antenatal classes. Our son ended up in the NICU after a harrowing delivery complicated by shoulder dystocia. His wide Aussie swimmer shoulders were stuck on my wife's pelvis. We eventually were discharged from the hospital and were set up with midwives who came out to our home every day to check on our baby's crib to make sure that it was safe, help us with breastfeeding, and help to make sure that Maddie was doing okay. Breastfeeding was incredibly challenging for us. We were referred to the hospital where a lactation consultant helped us out. I remember sitting in that room on the edge of desperation, hoping that we could get help with the most basic of tasks, to feed our child. At that appointment, Maddie was flagged for postpartum depression, and she was referred to the hospital for physical therapy and counseling. A team of local grandparent volunteers were available to cuddle the babies while Maddie was in her appointments. We felt empowered to be with our son, and it gave us the best start possible to our parenting life. How was all of this made possible? I've told you multiple times before that we didn't pay for any of this. Of course, I'm being a little facetious. We did pay for it, but with our taxes, a single payer system. Let's fast forward to 2024. Working in an American emergency department, you can get a little nervous. You truly never know what you're going to find when you walk into a patient room. I walk into a patient room and I find parents sitting there, cuddling their baby. I recognize the picture. They had the same look of desperation that Maddie and I had all those years ago when we were sitting with the lactation consultant back in Australia. So I continue. G'day, my name's Dr. Coyce. How can I help you today? My bulletproof phrase did nothing to ease their trepidation. They were struggling with breastfeeding, and the mother was suffering from postpartum depression. They had been referred a lactation consultant, but their insurance didn't cover the cost of the services, and they couldn't afford it out of pocket. I had little other services to offer them. My heart broke a little bit, and I gave them an impromptu breastfeeding lesson and then referred them back to their primary care provider. This story is not unique. I regularly see patients in the emergency department who decline simple pain relief medications like ibuprofen because they are worried about the cost of the medication. I've listened to babies' hearts that have murmurs who are waiting for their insurance company to approve an echocardiogram their doctor has already ordered. I had a patient with a bleeding hematoma in his leg discharged from the hospital against medical advice because he's worried about the cost of staying in hospital. It boils my blood that folks have to go through this. I also see patients in the emergency department for primary care related concerns, medication refills, poorly controlled high blood pressure, simply because their employer changed their insurance provider and their primary doctor is now out of network. Primary care related emergency department visits are strongly correlated with uninsured status and poverty. Approximately 27% of the non-elderly population use the emergency department for their primary care related needs, and they don't have continuity of care. For those of you who have had the misfortune of coming to the emergency department, you know it's not exactly a relaxing day spa in there. People yelling, alarms going off, people running around butt naked. It's not the ideal environment to have a meaningful conversation about your high blood pressure or how to get more fruits and vegetables on your plate. Compounding this, those that receive primary care in emergency departments are more likely to be racially minoritized, live in poverty, and are less likely to receive preventive care. The national insured rate in the US currently, 2023, is 7.7%, down from pre-ACA levels of around 16%. So when we think back to those graphs I showed you earlier of preventable disease rates, we can better understand that millions of Americans receive delayed care, no care, or suboptimal primary care from someone like me in emergency departments. Once a month, I sit by my front door and I wait for the mail person to deliver my bundle of medical journals. 2 papers have caught my eye recently. The first, a blueprint for healthcare in the US. They argue for that healthcare in the US should be automatic and universal, free and basic. Sounds pretty ideal, right? But how feasible is it? Another paper from 2020 performed an analysis of the Medicare for All Act. They found that a single-payer system in the US would cost around $3 trillion per year, but would save $458 billion compared to the current system. In doing so, we'd save 68,500 lives per year. We could reduce preventable death rates, we could decrease neonatal and maternal mortality, and we can increase life expectancy in this country. The mechanics are simple. Everyone who uses the system pays into the system, and the system covers the care for everyone involved. So, who is the villain in this story? It's the entities taking from the system but not contributing. It's the middlemen who are feeding at the trough but not doing anything to improve the provision of healthcare or improving access to services. I don't want to leave you in despair. This is my commitment. I will continue to show up every day and help people on the worst day of their life. I will continue to advocate for change so people can get the care that they need. My dream for healthcare in the US is simple. I want everyone to be able to get the care they need without the fear of bankruptcy. I want to be able to spend my time listening to my patient, helping them with their needs, and not spending that time on paperwork and pre-approvals. But that won't be enough because you have to help. You have so much power to make change. You can support direct primary care in its pure form as it offers a viable alternative to the current system. You can be the thorn in the side of your insurance provider. When you get a bill, call them. Ask them how you can reduce the price. You wouldn't go to a restaurant and order items off the menu without knowing how much those items cost. Demand price transparency. So, why do Australians live longer? Apart from the accent, we really aren't that different. We're actually pretty clever in Australia. We came up with a system that values preventive care across the lifespan. Healthcare systems exist on a spectrum. On one end, our system. On the other end, single payer. We can change course and we can land somewhere different on that spectrum. However, we have to have the courage to act. So if a bunch of larrikin Aussies can come up with a healthcare system that values preventive care across the lifespan and helps folks live longer, surely here in the land of the free, we can too. And who knows, if we do, perhaps we'll clean up this bloody mess and we'll shrink that life expectancy gap down to 0. Thank you.